welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at upper and lower GIT bleeding. So if you haven't yet subscribed, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. Like I said in my previous videos on these review lecture videos, there is a different style of which I will be doing these videos from now on. So we do start off with the warm-up question. This is a single best answer. So a 52-year-old man with a history of alcoholism presents sudden onset bright red hematemesis, which is vomiting blood, obviously. Upon questioning, the bleeding is so severe that he is unable to give a detailed history through an examination, though an examination reveals the presence of spider nevi and ascites. From this information, select the most likely diagnosis. So you have hiatal hernia as option A, acute gastritis as option B, Mallory-Weiss syndrome as option C, esophageal varices as option D, and a perforated peptic ulcer as your option E. So actually read through this question, keep your answer, and we will give you the answer at the end. So today we're going to be looking at upper GIT bleeding. So remember that the gastrointestinal system can actually be divided into a proximal part, or what we refer to as the upper gastrointestinal tract and the lower gastrointestinal tract. And what actually divides this is a ligament that's known as the ligament of Treitz. Remember that this is where you're going to have the anatomical separation between the duodenum as well as the jejunum. And so everything before the ligament of Treitz is referred to as upper GI. Everything after the ligament of Treitz is referred to as the lower GI. Now remember that the mortality rate is about 10% and usually results from complications of the underlying disease rather than exsanguation. Remember that exsanguation is just pretty much draining an individual of all the blood. And the risk of actually having a rebleed is quite low, and the risk of rebleeding is low if bleeding occurred more than 48 hours before the presentation. Now here are some of the important causes that you really need to know. From all these causes, you should know at least 10 important causes, because this actually does tend to show up on your exams. So you have peptic ulcer disease, which accounts for the most of the cases. Remember, peptic ulcer disease is often attributed to Helicobacter pylori infection as well as NSAIDs. So you may have an ulcer erosion into a blood vessel, which is common especially with the posterior duodenal ulcers. You may also have gastroesophageal varices. These are very common in patients that have cirrhosis or patients with schistosomiasis. Now remember that the blood that's pretty much coming from the intestines has to first pass through the liver via the hepatic portal veins. Then from the liver, this blood has to be drained into the inferior vena cava via the hepatic veins. Now, in these individuals that have cirrhosis, this channel is blocked and blood cannot flow through this channel. So it uses an alternative. It uses these shunts. One such shunts are found in the submucosal or the submucosal area of the esophagus. These are blood vessels that are found there. So they may actually dilate and result in these esophageal varices. This can actually rupture. Now, with this type of bleeding, it's going to be painless bleeding, and the person will characteristically have a history of having had alcohol or maybe swimming in a water body in the case of schistosomiasis. You may also have a Mallory-Weiss tear, which is often following severe vomiting. This tends to be quite painful. You may have gastroesophageal reflux disease. You may have drugs like aspirin and NSAIDs, inflammatory conditions like esophagitis, gastritis, erosive gastritis, like in HIV patients. You should consider cytomegalovirus, herpes simplex virus, as well as candida, as well as duodenitis. You may also have gastric cancer causing upper GIT bleeding. You may have gastric vascular ectasia, Cameron's ulcers. You may also have submucosal artery. This is a special type of lesion. You may have an aortoenteric fistula, as well as hemophilia, which is mixture of blood and bowel, obviously due to surgical and non-surgical trauma. Here is a schematic picture to help you actually remember the causes. Recall that you should know at least 10 of these causes. Now, how are you going to take your history? Of course, you're going to be asking for a history of nausea, a history of retching prior to hematemesis that will be suggestive of a Mallory-Weiss tear. You may have hematemesis. Remember that these people tend to vomit fresh blood. There's a difference between hematemesis and hemoptysis. Hemoptysis is coughing out blood. Hematemesis is vomiting blood. So they may vomit fresh blood, or it may be coffee ground. Remember that some of this blood can remain in the stomach, and the stomach can begin to digest it because it has acid. And if it's coming out from the mouth, it's going to be coffee ground. Of course, if it's coming out as stew, it's going to be decolorized because pretty much there's going to be some digestion of the red blood cells and other components in the blood. And of course, as little as 50 mils of blood is needed in the GIT to cause melena, which is this dark tar-like stew. You may have dyspepsia, abdominal pain, a history of hematochezia. Now, we only get to see this if someone has an upper GIT bleeding that is bleeding very quickly. So it means that they have a massive bleed from the upper GIT. You may get orthostatic hypotension, and in patients that have a chronic slow upper GI bleeding, they may present to you with a positive occult blood test. Then you may also see chronic iron deficiency anemia in these patients because they keep losing blood. Then, of course, general features like nausea, epigastric pain, syncope, lightheadedness, dizziness, fatigue may also be there because of the anemia that's underlying. You may get history of alcohol use. You should suspect variceal bleeding or esophagitis or even Mallory-Weiss tears. If you get a history of NSAID use, you should be thinking of peptic ulcer disease. A prior history of an abdominal aortic graft, you should think of aortoenteric fistulas. And then, of course, if they have a history of chronic gastroesophageal reflux disease, think of esophagitis. Then, of course, there may be a history of weight loss and even iron deficiency that may point you towards certain malignancies like gastric carcinomas. Then, of course, when you do your physical examination, do not forget to do a digital rectal examination. Check if there's any fresh blood on the glove or if there's any dark stew on the glove. Then, of course, check for features of anemia like pallor. You may get a tachycardia. You may get stigmata of chronic liver disease like spider angiomas. You may get ascites. You may even get some jaundice. Then, of course, you will be able to elicit that this person is hypotensive and they may have orthostatic hypotension. Now, how exactly do we define orthostatic hypotension? If you have more than 10-point rise in the pulse of a patient when they go from the supine position to the standing position or to the sitting position, or a greater than 20 points drop in the systolic blood pressure when they change from the standing position, or rather supine position, laying flat, to standing or sitting. Now, of course, these measurements should be actually taken at least 1 minute in between the position changes to allow at least for the body to adjust, because here you have a failure of the body adjusting to the changes in the position of an individual. And remember that when you have orthostasis, this is going to be pointing you towards, is this individual losing about 15 to 20% of their blood. Now, sorry for the very bulky slide. What are some of the investigations that we're going to be ordering? Of course, we want to determine first whether this is an acute bleed or it's a chronic bleed. So we want to ask for the number of times that they've had these bleeding episodes, the most recent episode, any evidence of abdominal pains, any evidence of weight loss, use of aspirin, NSAIDs, alcohol, cirrhosis, risk factors of schistosomiasis. You want to ask for that. When you examine the patients, you want to check for the hemodynamic stability. So check their blood pressure, check their heart rate. Of course, ask for other features of anemia like lightheadedness, syncope, dizziness, and orthostatic vital signs should be taken, and they tend to be positive when someone has had significant blood loss. Again, like I said, do not forget to do a digital rectal examination. So on our investigations, we're going to be ordering for a full blood count. Of course, this in chronic or even subacute bleeding, they may have anemia, but the hemoglobin concentration may be normal after a sudden major bleed until the hemodilution actually happens, where you replace the fluid that you have lost from the blood component, but the red blood cells usually take some time to be formed. Remember that the process of red blood cell formation takes roughly about 1 week. Then thrombocytopenia may also be a clue that may point you towards hypersplenism, like for example in chronic liver disease. You may also order for a stool or cord blood, where you check for these blood cells, the red blood cells in the stool, in the presence of blood in the stool that you can't see, the microscopic blood. Then, of course, you will also order for urea, electrolytes, and creatinine. This may show an evidence of renal failure. The blood urea levels tend to rise because of the absorbed products in the lumen, and the blood is being broken down, is being metabolized by the liver. Then, of course, you get an elevated level of urea, but you have normal levels of creatinine, meaning that there is some severe hemorrhage. Then, of course, the liver enzymes may be raised in patients with chronic liver disease. You check your clotting profile, your clotting panel, your prothrombin time, your partial thromboplastin time, and your international normalized ratio. You also cross-match this patient. You should have at least 2 units of blood that should be cross-matched, and you may sometimes perform an NG tube lavage. So this is useful if it's positive. Then you're going to get red blood cells. You may get a coffee ground aspirate that you get. Then if you pull out fresh blood, then this is obviously an active bleed. You push in an NG tube, you push in some normal saline in, and you pull out, or you push in the NG tube, you try and aspirate from the NG tube. If you aspirate fresh blood, then most likely this is an acute or an active upper GI bleeding. If you pull coffee ground material, then this is obviously a recent bleed. Then of course, if you pull bilious material, then this in its own doesn't really exclude this person from having GIT bleeding. Then, of course, you also order for H. pylori testing, the stool for the H. pylori, to check if this patient may have H. pylori causing the ulcers. You also perform an endoscopy, especially when this person has been stabilized and resuscitated, and this should be done within at least 12 hours of admission. This is done for diagnostic purposes, it's done for therapeutic purposes, it's also done for prognostic purposes. Now, how do we manage these patients? Now, they may come in actually in shock, so you pretty much want to stabilize this patient. So your ABCs are very important. Clear the airway, ensure that this patient is breathing, give oxygen via a face mask. This patient shouldn't eat anything. Consider putting in an NG tube. Of course, 2 large bore cannulae is a must. If the patient is actually in shock, then you pretty much want to treat them with aggressive intravenous fluids. So you want to give them either normal saline or even Ringer's lactate, and then of course cross-match these individuals. The goal is to get the hematocrit 25 to 30% or above in older individuals, and also in individuals that have coronary artery disease. So if you suspect variceal bleeding, then you should start normal saline cautiously. And of course, cross-match this individual, administer packed cells, and of course, if they are actively bleeding and their platelet count is less than 50,000 cells per ml of blood, or if there is a known impairment in the function, like uremia, or they are taking aspirin, then of course transfuse this patient with platelets, or you can give them desmopressin with active bleeding and an increased prothrombin time, as well as international normalized ratio that's greater than 1.5. Transfuse this patient with FFP. Then also put a Foley's catheter to monitor your urine output. Remember that your normal urine output should be 0.5 to about 1 ml per kg per hour. Get your vitals hourly, your pulse, your blood pressure, your urine output, your temperature, respirations, and your pulse rate. Then of course there is medical therapy that can be done. Want to cover this patient on proton pump inhibitors, so give omeprazole 40 milligrams twice a day. Also monitor your urine output on all your patients that have proton pump inhibitors. Then of course you can initiate a proton pump inhibitor as a drip at 8 milligrams per hour for the first for 72 hours if an esophageal gastroduodenoscopy suggests the high risk of this person having a rebleed. For example, if you do your endoscopy and you realize that there's active bleeding, or there's a visible blood vessel, or there's an adherent clot, then you'd want to start your proton pump drip for your 72 hours. Then of course this reduces the relative risk of bleeding by about 50%. You may give IV octreotide for suspected variceal hemorrhages. Continue for 3 days until you verify by endoscopy. Then this is meant to decrease the portal hypertension. Then if they are having some coagulopathies, give them vitamin K if they have signs of liver disease. And then of course this can be given as vitamin K 5 milligrams IV stat dose. Then propranolol, which is a non-selective beta blocker, can be used as long-term management in patients that have portal hypertension, because this actually decreases the frequency of the bleeding. Everyone with varices from portal hypertension and cirrhosis should actually be on a beta blocker. Then of course cover these patients on broad-spectrum antibiotics if they have suspected liver disease. Now, when you do your endoscopy, remember that endoscopy can be both diagnostic and therapeutic. So your endoscopy is actually carried out immediately after you resuscitate the patient, ideally within 12 hours, but if you're pushing it, 24 hours, and this will actually yield a diagnosis in about 80% of the cases. Now, patients can actually be treated with endoscopy, so you may perform banding, where you actually tie the varices with these bands. It's actually done with an endoscopy. Then, of course, you may perform other procedures like thermal coagulation, where you use a heater probe. You may may inject a sclerosing agent, you may inject epinephrine, you may actually perform electrocautery. And then, of course, predictors of rebleeding include things like significant comorbidities, the size of the lesion, the high risk of stigmata, like for example, if you have a visible blood vessel on your endoscopy or you have an adherent clot. Then of course, if the patient has this recurrent bleeding that's not responding to whatever you have done, then you may use what is known as an esophageal balloon tamponade, where you actually push in a balloon, inflate it within the esophagus, and it will compress on these blood vessels and it will pretty much stop the bleeding. And of course, for varices, this can be done. And as you're doing this, you're of course organizing for this person to go for a shunt procedure, which is known as a transjugular intrahepatic portosystemic shunting. So here you're going to get a catheter and we're going to place it into the jugular vein, and we guide this catheter radiologically through the liver to form a shunt between the systemic circulation in the hepatic vein and the portal circulation through the portal vein. And of course, this has largely replaced the need for surgically placed shunts, and is the most common thing that's going to be used. And long-term complications of the same procedure is of course causing hepatic encephalopathy, because the liver is not going to be removing most of these waste materials. You may also perform an angiogram where you actually cause an intra-arterial embolization or surgery to stop the bleeding that's refractory. Then of course surgery is indicated when you have when you fail to actually stabilize this patient by your endoscopic measures, or if this person keeps on rebleeding, or if they are in an elderly patient, or if they are frail, or twice even in a younger, fitter patients, then if available, you can perform angiographic embolization. It's quite effective alternative for patients that are too weak to go for theater. Then of course the choice of operation depends on the site and the diagnosis of the lesion. More or less, the discharge depends on the patient's age, the diagnosis, the comorbidities that are present, the presence of any other symptoms or any other complications like shock, and of course the availability of support and help wherever they are going. And you should consider all these things. And in general, most patients who are hemodynamically stable, they do not have any features of recurrent hemorrhage that puts them at risk of it happening. Then they are usually kept in the hospital for about a day, and then they can be discharged after that. But those that have comorbidities can be kept for a longer period of time. Now, here is a table giving you the low risk, the moderate, and the high risk, and a summary of the management. So you can actually pause the video at this moment here and actually get a screen grab of this, because this is the most important thing that summarizes everything that I've been talking about. And of course, we'll move on to lower gastrointestinal bleeding. So this is bleeding from a source that's distal to the ligament of Treitz, and more than 95% of these cases are actually going to be arising from the colon, and 85% of them are self-limited. So they may be due to hemorrhage from the colon, or from the anal canal, or even from the small bowel. Now, it is very useful to distinguish patients who present with this profuse bleeding and active bleeding from those that present with this chronic or subacute type of bleeding, which is of less severity. Now, what are some of the causes? Causes include diverticulosis or diverticular disease or Merkel's disease in 40% of the cases, angiodysplasia, vascular ectasia, neoplasms like carcinomas, these are quite common. Then fissures, you may also have inflammatory bowel disease, ischemic colitis, hemorrhoids, infectious causes like hookworms, post-polypectomy, you may have NSAID ulcers, you may also have radiation colitis, rectal varices, you may also have solitary rectal ulcer syndrome. So again, you should know at least about 10 of these causes. Here's an image to show you the different locations where you get some of these ulcers happening. And of course, what clinical features are we going to get? So usually these individuals tend to be asymptomatic, but they may present to you with abdominal pain and abdominal cramps rather, and to a lesser extent abdominal pain. You may get features of orthostasis or orthostatic hypotension in severe cases. You may also get signs like hematochezia. So this is a difference between upper GIT and lower GIT bleeding. In upper GIT bleeding, we were getting melena. Here we're getting fresh blood. But remember that you can also get fresh blood from upper GI bleeding if it's happening at a much more severe rate, or it's happening at a very, very quick rate. Then, of course, you get this fresh blood in stool. You may sometimes also get melena, especially if it's coming from the small intestines. You may get pallor, and chronic bleeding tends to present as anemia, so iron deficiency. They'll have a very low HB. Then, of course, there may be some abdominal distension with tenderness. You may get hypotension and tachycardia. Now, the demographics and history, the age of this, patients that come in with lower GI bleeding tend to be elderly, and they actually come in with this, sometimes they may come in with as asymptomatic patients, like for example in diverticular and even vascular ectasias, and then in young individuals they may present with pain, so it may be due to infectious causes or inflammatory causes. Then of course the description of the first blood that's seen by the patient is very important. So if you get bright red, this indicates that it's happening at a much more distal area, or it can be happening rapidly in the proximal area. And if it's black or maroon, then this is pointing you towards more or less an upper GIT bleeding, much more proximal to the upper end of the GIT. Then of course, do not forget to perform a rectal examination. Now, investigations are pretty much the same. This is exactly the same slide that we used with lower GI bleeding. The only difference is that we added to this slide, of course, your anoscopy to exclude any anal sources of bleeding. So for those that have mild and moderate bleeding, then you consider a nasogastric lavage and urgent colonic purge. Then of course, with massive bleeding, endoscopy should be done to rule out upper GIT bleeding. You can also do a technetium labeled red blood cell scan and even mesenteric angiography. Then of course, more than 6 units should be transfused, and you should consider surgical intervention. Then of course, you may do your diagnostic colonoscopy, even your proctoscopy, to actually pick out the actual cause of the bleeding, among other lower GIT investigations that can be done on this slide. I think you can take your time to actually read this, but essentially it's pretty much lower endoscopic studies. And of course, the stabilization is exactly the same as we stabilized patients with upper GIT bleeding, so there's nothing different here, it's exactly the same. Then of course, medical treatment, we also want to give these individuals a therapeutic urgent colonoscopy, and then of course pure large purge with greater than 6 liters, cautery or even injection of epinephrine, or even clipping of the blood vessel can be done. Then of course colonoscopy is technically challenging with brisk lower GIT bleeding, and urgent colonic purge requires sedation, and then of course visualization is quite poor. You may sometimes perform mesenteric angiography or embolization, which is the intervention of choice when you have a low brisk GIT bleeding, and is associated with 80 to 90% cessation of bleeding for those with diverticular or even vascular ectasias, though 50% can actually occur and experience rebleeding. And of course, surgery is indicated with active lower GIT bleeding involving more than 4 to 6 units of blood in 24 hours or greater than 10 units in total. And if the site is well localized, consider hemicolectomy, otherwise perform a total abdominal colectomy where you want to actually remove this part of the bowel. Then of course, you ask me, is there any role of the histamine type 2 receptor antagonist and even proton pump inhibitors? There is actually no role of this. If they are taking aspirin, discontinue that. If they're taking NSAIDs, discontinue that. That's the difference between this and upper GIT bleeding. Upper GIT bleeding, we do advocate for giving proton pump inhibitors. We don't give that here. And then of course, if they have anemia, then you should actually give them oral iron. So back to our warm-up question. We had our 52-year-old history of alcohol intake, presents with sudden onset of bright red hematemesis, and upon questioning, the bleeding is so severe that he is unable to give a detailed history, though an examination reveals the presence of spina nevi and ascites. So this person has some liver disease, and they may have some cirrhosis because they have a history of alcohol intake. So the most likely cause that this patient may come in because they're vomiting bright red blood, this is most likely esophageal varices. They haven't given us enough information to warrant any pain, so that's how we rule out Mallory-Weiss tears, perforated ulcers, acute gastritis, and of course hernias rarely do present to you with a history of alcohol intake and a history of vomiting bright red blood. I really hope you enjoyed watching this lecture on upper and lower GIT bleeding. If you did, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Until next time, my name is Dr. Moses Kazevu. Bye-bye.